All of you have been to the doctor at some point in your life, but have you ever wondered how doctors get paid? What if how doctors get paid affects the way they interact with and treat their patients? Most physicians are paid on a fee-for-service model in which they are paid based on the number of patients they see, tests they order, and procedures they perform. However, there is an alternative model known as value-based payment that is emerging in healthcare facilities across the country and is attempting to pay doctors based on how well they are able to treat their patients and keep them out of the hospital. Today, I'm going to inform you of the pros and cons of a value-based payment model for physicians. After extensive reading on the subject, I believe I'm qualified to speak on the topic. I will explain how it focuses on patient care, lowers hospital visits and medical costs, requires more money to pay for value assessment tools, and how value assessment tools are lacking. Let me begin by discussing the benefits of a value-based payment model for physicians. The first benefit is that a value-based payment model puts more emphasis on patient care and patient satisfaction. Baylor Scott & White Health System is a hospital chain in North Texas that is transitioning towards a value-based payment model. Their doctors are incentivized to spend more time with their patients and discuss their health. Jim Landers, writer for the Dallas News website, stated that half of physicians at Baylor Scott & White Health System are paid a salary based on the value of their work, where doctors frequently engage their patients in conversation about diet, smoking, exercise, and other habits. Fee-for-service payment models do not pay for patient time. By shifting the primary payment incentive of doctors away from the quantity of services they provide, they can better focus on treating their patient in a way that is most beneficial to their patient's needs. The health journalism website author Joanne Keenan put this well when she said, "Physicians would make decisions based on the best patient outcome rather than choosing procedures that the hospital would make money from." The second benefit to a value-based payment model is that a value-based payment model focuses more on keeping high-risk patients out of the hospital, potentially lowering medical costs. High-risk patients are those who are typically elderly, have 2 or more chronic illnesses, and are admitted to the hospital multiple times a year for their condition, which can have exorbitant costs. Physician Rushika Fernandopoulos started an experimental clinic using a value-based payment model in Atlantic City to tackle the problem of high-risk patients in the area. The New Yorker, January 24, 2011, explained how the Special Care Center in Atlantic City pays physicians a flat monthly fee for each patient and gives patients unlimited access to the clinic. Of their 1,200 patients, ER visits and hospital admissions were reduced by more than 40% after 1 year. Statistics like this provide evidence that value-based payment could potentially provide patients with the care they need while also lowering medical costs. Value-based payment plans would encourage physicians to respond to patient phone calls and about symptoms or problems, which can avoid expensive visits to the hospital or emergency room. Fee-for-service models do not encourage this kind of behavior. According to the Center for Healthcare Quality and Payment Reform website, under the fee-for-service system, providers don't get paid at all when their patients stay well. Now I will discuss some of the disadvantages of a value-based payment model. The first con is that accurately assessing the quality of a patient's care requires additional tools and expenses that may outweigh the benefits. Value-based payment models will require some sort of quality assessment tools for physicians in order to keep track of their patient outcomes, the quality of their care, and to collect data on patient outcomes. These tools are likely to cost a large amount of money. In the fall 2016 issue of Deloitte Insights, Michelle Morris, MD, Ken Abrams, MD, Natasha Elsner, and Wendy Gerhardt stated that quality reporting is estimated to cost $40,000 per physician per year. As of right now, there's not a lot of data regarding the actual financial improvements that would occur if value-based payment models were adopted. Jonathan Oberlander, PhD, and Miriam Logson wrote in the fall 2015 issue of the New England Journal of Medicine that it is too early to conclude if value-based payment models will actually save money. The second disadvantage is that the quality and quantity of value assessment tools and care pattern data may be lacking. The same authors who wrote in the fall 2016 issue of Deloitte Insights also discussed in their article how these tools may not accurately measure the quality of care that a physician gives to a patient, and how these tools are absent for some specialties. Value is a vague term in medicine, so it is hard to accurately translate the value of a care that a patient receives into quantifiable measurements that can be used to determine how much a physician should be paid for their work. This could lead to doctors being paid less than they should be due to inconsistent or unclear value assessment tools. Also, in some specialties of medicine, such as oncology and nephrology, value assessment tools are rare. Many doctors in these specialties would not be able to participate in a value-based payment model because of this. In conclusion, value-based payment healthcare emphasizes patient care and satisfaction, potentially lowers expensive hospital and emergency room visits, requires more money to pay for value assessment tools, and value assessment tools are not always accurate. I hope you now have a better understanding of the benefits and disadvantages of a value-based payment model for physicians. Value-based payment models promise to pay doctors in such a way that will increase the quality of your care you are given the next time you walk into the office. But it remains to be seen if the concept can truly be effective for both the patient and the physician. Thank you.